ready, you can share your screen, but I want to take this opportunity to present you to our group today. So Zachary is originally, Dr. Weiss is originally from Albuquerque, New Mexico. He attended college and medical school at the University of New Mexico. He moved to Boise to do his residency training at the Family Medicine Residency of Idaho, which is now referred to as Full Circle Health. He followed that with a geriatric fellowship focusing on the care of older adults. Currently, Dr. Weiss practices family medicine and geriatric specialty care at the Saint Alphonsus Nampa 12th Avenue Clinic. So Zachary, we are so excited to have you here today. Thank you for joining us. We are able to see your presentation, so whenever you're ready, I will let you take it over.
All right. Well, can everybody hear me okay?
Yes, yes.
Great. Well, it's an honor to be here and to present to you all. So my name is Dr. Zach Weiss. I'm a family medicine doctor and geriatrician with Saint Alphonsus. And I work at the Nampa 12th Avenue Clinic, and I'm a part of the Saint Alphonsus Geriatrics and Memory Center Clinic. And I'm going to be presenting to you guys today on how a diagnosis of dementia is made and what patients and families need to know. So I'll go through my presentation, and then it sounds like we'll have time for questions and discussion afterwards. All right, so our objectives for today are we're going to talk about the definition of dementia, what dementia is, and then we'll talk about how a diagnosis of dementia is made. So here I have a picture of a diagram showing cognitive trajectories with aging. So we all have our own individual cognitive baseline. We're born with our certain IQ. We can't really change that. Most of us fall into a realm of average intelligence level. There are the Bill Gates and Stephen Hawking's of the world, and there are some people who have a lower level of intelligence, but we all have our kind of general baseline, and we kind of develop our cognitive skills as we grow up and go through school, and our cognitive abilities are fairly stable through adulthood. It's common, though, as we get into our 60s and 70s to notice a mild decline with our thinking and memory. Those so-called brain farts or senior moments, the walking into a room and forgetting what you were going in there for, or going to the grocery store and forgetting what was on your grocery list, forgetting names of people or places. Those changes can be frustrating, but we think those mild symptoms are just due to the normal aging of the brain. So that's what this green line here represents of normal aging. Now, what I don't have represented on here are the so-called super agers who they get into their 80s and 90s and are as sharp as they ever were. And we all hope to be one of those. And they are certainly doing studies on those folks as well. But most of us tend to fall into the normal aging category. Now, sometimes people may experience changes that are more severe or significant than what we'd expect for normal aging. And if those changes are significant enough to actually impact our ability to function and be independent, that's when we call it abnormal aging or dementia, and that's represented in purple there. So you can see that dotted line along the bottom represents above that as our cognitive skills are, we're able to maintain our independence with our daily activities. And if our cognitive skills fall below that line, we're not able to function the way we used to. So what is dementia? Well, I'm going to give you a couple definitions just to kind of help show what dementia is and what dementia isn't, and then we'll talk more about that. So the Alzheimer's Association says that dementia is a general term for loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with daily life. And Alzheimer's disease is the most common cause of dementia. The World Health Organization defines dementia as a term for several diseases that affect memory, thinking, and the ability to perform daily activities. Dementia is a syndrome that can be caused by a number of diseases which over time destroy nerve cells and damage the brain, typically leading to deterioration in cognitive function beyond what might be expected from the usual consequences of aging. So, Dementia is a clinical syndrome. So clinical means that it's a collection of symptoms and signs that we put together and get a diagnosis based on those symptoms. It's not diagnosed with a single test. Um, and so dementia is a clinical syndrome that's characterized by a decline in cognitive functioning and behavioral changes that are a change and a decline from someone's prior skill level and are severe enough to actually impact our daily functioning. These changes are not caused by an acute confusion or delirium, a sudden confusion, or are not due to a psychiatric disorder. And it's important to realize that there are many causes of dementia. There are different diseases, as we can see here on the right side. And so we think of dementia as this umbrella term, and these different diseases that can cause dementia are listed underneath it. Alzheimer's disease is the most common cause of dementia, and I think one that most people have heard of. You can see in this diagram below that Alzheimer's disease makes up about 75% of dementias, but there are other causes as well. And actually, more and more, we're realizing that in patients who have dementia, it's more common for patients to have multiple causes contributing to their dementia syndrome.
Hey,
And the thing
Dr.
to
Weiss.
realize, yeah.
Hey, sorry to interrupt. I don't think the slides are moving on my end. Is it moving other places? Okay, all right.
They
Sorry
look
about that.
okay on my end. Can anybody else? You've got your camera on. Yeah, I see some thumbs up. I think
I can see
we're
it okay.
Good.
Okay, thanks.
Yeah.
Okay.
Thank you for checking, Abhilash.
Sorry, yeah.
Yeah, no worries. Thanks for checking. So most cases of dementia can be diagnosed in the primary care setting. So moving to the next slide here. So there is a test that's done in the primary care setting to screen for cognitive changes. This is called the mini-cog, and some people may have seen this before or have done it in their Medicare wellness visits. The mini-cog test, there's two components. Patients are asked to remember three words, so apple, table, penny, and then are distracted by then asking to having them draw a clock. And so they're asked to draw the circle of the clock and put in the numbers and put in the hands at 10 after 11, and then are asked to recall the three words. And so we grade this screening test based on how well the clock is drawn and whether they're able to remember the words or not. So let's go to a case here. So Mr. Smith is an 84-year-old male who has been my primary care patient for the last 5 years. And I'm seeing him today, and his daughter is with him and reports concern about worsening short-term memory. And then we did the mini-cog test, and he performed poorly on this test. So the question is, where do we go from here? Let's see. So the evaluation, to evaluate a patient with cognitive concerns, the most important part, like most things in medicine, are getting a good history. The difference in evaluating a patient with cognitive concerns or memory changes is that we want to get history both from the patient and from a family member or a caregiver or someone who knows them well. Things that we want to learn from them include what symptoms they're having, how has it affected their daily functioning. We want to know about their past medical history, if they have any psychiatric problems. We want to know more about their background, their habits, their education, their occupation, and family history. We also want to review their medications and supplements, do an exam, do a cognitive evaluation, and also this will include getting some lab tests and brain imaging. So when getting a history, again, getting history from a family or caregiver or someone else is critically important to getting an accurate history. So we want to talk to someone who knows the patient well, and ideally talk to them separately from the patient, because often it can be hard to talk about someone in front of them, and we want to make sure that we're getting as good a history as possible. So when getting a history, we want to know what the patient's, Mr. Smith's prior baseline was, and then what changes have been noticed from his prior baseline. So a common question we'll ask is, if we think back in time, when do you think he was last his previous self? We want to know about the time course of these changes. Has it been an abrupt change? Has there been kind of a slow progressive change? Has it fluctuated? And have these changes occurred in the setting of an illness or any new medications? We also want to know about the living situation and any safety concerns. So when we're getting more information about Cognitive symptoms, we ask about different cognitive domains or categories of mental processes that we use. So we commonly think about memory, but there are many other cognitive skills or processes that we use, including language, executive functioning, attention. So we'll go through those now. So to start with, we're going to ask about memory. So memory is the most common complaint that we get, but a lot of times we find patients come in with concerns about their memory, but it actually might be something else. So memory or short-term memory is our ability to recall what happened recently, whether it was an hour ago, a week ago, a month ago. So questions we'll ask Mr. Smith and his daughter, is he repeating questions or stories within a short period of time? Is he forgetting appointments or recent important events? Is he leaving the stove on? Is he misplacing items or losing items? We'll also ask about distortions of memory, like falsely remembering that he's turned off the stove or taking his medications, or has he substituted one person in a memory from another, or combined two memories together, or has he thought that a memory from a long time ago occurred more recently? Language skills, so our ability to communicate through speech, both understanding and speaking, as well as writing and reading. So does he seem to search for words while speaking? Are family members having to fill words in for him? Is he saying the wrong word or wrong sounds within a word, or having trouble understanding single words despite having normal hearing? Visual perception and spatial perception. So this includes driving abilities, spatial awareness and attention, and object perception. So with driving, is Mr. Smith getting lost? Is he making wrong turns? Is he getting confused, especially in familiar areas, places that he's been in regularly for a long time? Has he had difficulty planning new routes? Other questions include, is he missing objects in full view despite having normal vision? Is he having trouble reaching out for objects within reach? Is he bumping into things over frequently, or is he having difficulty lining up the car when parking it? Executive functioning, so our ability to plan, organize, multitask, and persist through a task. And attention, our ability to focus, concentrate on a task or thought. So is Mr. Smith had difficulty planning out or carrying out an activity like a simple repair or hooking up the VCR, preparing a meal that he had previously been able to do? Is he having trouble managing the finances or paying his bills, tasks that require a little more concentration and planning out? Have we noticed that he's given up a hobby or interest that he used to enjoy doing because it's been too difficult? Is he becoming more easily distracted compared to how he used to be, or is he less mentally efficient? Reasoning and judgment, so our problem-solving abilities and making decisions. Has Mr. Smith made any poor decisions? Has he been scammed? Has he been exploited in another way? Do you think that he could respond appropriately in an emergency situation? Would he know the number 911 to call? And social and emotional uh, ability. So our ability to relate to others and react to others, to show empathy and sympathy. So has there been any big change in personality? Is Mr. Smith still the same guy he's always been, or has there been a kind of a dramatic change in how he is as a person? Has he seemed unaware in social contexts, like behaving inappropriately in public settings or made inappropriate comments? Has there been any loss of empathy, or has he been more apathetic? Have there been any new rituals or food preferences? And finally, behavior issues. Has there been any depression, anxiety? Again, has he been apathetic? Has he been irritable? Has there been any paranoia or suspiciousness, any hallucinations? And we also want to know, is he aware of these changes? Some patients are, and especially early on in dementia processes, but sometimes patients aren't aware of their symptoms. So we also want to know about functioning. So how well is he functioning, and has there been a change in his ability to function on a day-to-day basis, or are these changes affecting his personal relationships? So um, the common ones we ask about initially are the instrumental activities of daily living. So these are the things that we learn to do when we move out of the house and live on our own. So how are things going with driving, shopping for groceries, doing housework? How well is he keeping up with the laundry and cooking? How well is he managing his money and paying his bills, managing his medications? Is he taking them regularly? How well is he able to use the phone? And then the instrumental, the basic activities of daily living are the kind of basic day-to-day things when we do when we get up in the morning and go to bed at night. So eating, bathing, grooming, going to the bathroom, dressing, walking, and so forth. And to kind of clarify too, what we want to know is, have there been inefficiencies? Is he kind of less efficient at doing some of these tasks, or is he truly not able to do these on a regular basis? And then safety concerns we want to ask about: risk of fire and flood, with leaving the stove on or the faucet on, falls, making mistakes with medications, making mistakes with finances, driving concerns. Are there guns in the home? Are there aggressive behaviors? So that's the bulk of the history of what's been going on with the concern about memory, thinking, and so forth. But now we want to get some more background information because we want to rule out potential medical, neurologic, or psychiatric causes of cognitive changes, any reversible causes. So these include adverse medication effects, depression, delirium, hypothyroidism, vitamin B12 deficiency, or sleep problems. So we're going to ask about past medical history and medications. We're going to do an exam. We're going to do a cognitive test and a mood assessment, and also look at getting some blood tests. So we want to ask about past medical history, particularly if there have been history of strokes or seizures, any history of sleep apnea or depression. Medication review is really important. Ideally, it's best to have patients bring in all their medications. So in our clinic, we always ask that patients bring all their medications, both prescription and over the counter, so we can review. Because a lot of times patients are taking medications for sleep or for allergies that aren't on the med list and that we're not aware of. But over the counter sleep and allergy medicines like Benadryl or Tylenol PM can have a really significant impact on dampening our cognitive functioning and can be contributing to symptoms. And we can actually improve patients by just making simple changes with their medications. Prescription medications we also want to ask about include pain medications, sedatives like Ambien, and even bladder medications can have a significant impact on brain functioning. We want to get background information on Mr. Smith's education level, occupation, what kind of social support he has, his habits and behaviors like alcohol use, tobacco use, drug use, any family history of dementia, and is there a history of learning disability? We want to do a physical exam, particularly looking for hearing difficulties, because we know that hearing impairment can have a significant impact on someone's ability to remember things. If they can't hear something in the first place, that is going to make it difficult for them to remember. So I always make sure I look in patients' ears too, to look for earwax impactions and looking for signs of prior strokes or Parkinson's disease. So we have different cognitive assessment tools to evaluate someone's cognitive domains or processes and thinking. So the one that we typically use is called the Montreal Cognitive Assessment, or a MoCA for short. It takes about 10 to 15 minutes to administer, and it evaluates those different cognitive domains that we talked about. So visual, spatial, and executive functioning, the kind of problem solving, multitasking, looks at language ability, short-term memory, attention, and abstract thinking. So these are the different sections of the Montreal Cognitive Assessment. We also want to screen for depression because we know that depression can, someone who's depressed can actually have difficulty with their memory, and that can actually look like dementia. And oftentimes dementia, so a patient with dementia can also have depression symptoms. So neuropsychological evaluation. So sometimes we'll actually refer patients to a neuropsychologist for a much more in-depth evaluation. So in contrast to a 10 to 15-minute cognitive test in the clinic, a neuropsychological evaluation involves seeing a specialist, a neuropsychologist that does hours of testing on a patient to get a much more in-depth sense of strengths and weaknesses in different areas. So we sometimes refer patients for this when there is a patient who is screening normal in our clinic, but family members or patients are still concerned, or someone who has a high intelligence level at baseline or a low level of cognitive functioning at baseline, like someone who's had a brain injury or developmental delay like Down syndrome. Also, if someone has a known psychological or psychiatric condition like schizophrenia or really bad depression, it can be helpful to have a neuropsychologist help in that evaluation. And finally, we want to do some blood tests. So the point of doing these blood tests is to rule out reversible causes. So we know that hypothyroidism and vitamin B12 deficiency are common and that they can actually have a profound impact on cognitive functioning. And we can fix this pretty easily by just giving extra B12 or thyroid. So we always want to check for those. We check for other kind of basic labs as well. And also think about doing a sleep study because we know that we can actually help improve patients' cognitive functioning by treating their sleep apnea. And then finally, brain imaging. So if we're worried about a patient's cognitive levels and we're worried about dementia, we always get a picture of their brain. So either an MRI or a CT scan to look for signs of atrophy or shrinkage of the brain or brain cell loss. We also want to look for signs of small strokes and also rule out other things that we wouldn't expect to find, like a prior stroke or high pressure on the brain, or a tumor or bleeding in the brain. So here is a picture you can see on the bottom left corner here. We have a healthy older adult, and next to it, we have a patient with Alzheimer's disease. And you can see that there's significant brain loss, brain volume loss in a patient with Alzheimer's disease there. So this is an important reason, one of the reasons why we want to get brain imaging. Finally, I just want to talk about molecular biomarkers. So these have been in the news recently. Let's see here. So in May of this year, the FDA approved the first blood test in diagnosing Alzheimer's disease. So what is this test? So this test is actually looking at measuring the proteins involved in Alzheimer's disease. So these different types of dementias are caused by abnormal proteins that build up in the brain and cause damage to the brain. In Alzheimer's disease, those two proteins are amyloid and tau. And so we now have blood tests that we can do that measure the levels of these two types of proteins, amyloid and tau, and they can give us an idea of the likelihood of someone having Alzheimer's disease as a cause of their symptoms. Now, back, 10, 15, 20 years ago and before, the only way we could truly diagnose Alzheimer's disease in a patient was on autopsy. After a patient had passed away, doing a biopsy of the brain to look and find these abnormal proteins in the brain. But now we actually have ways we can measure and find these proteins either in the blood, which are the new tests, but they're also biomarker tests that we can do through cerebral spinal fluid, through a spinal tap, or through an advanced imaging technique, either through called a PET scan. These PET scans are not available in Idaho. So I just wanted to bring that up, and we can certainly talk a bit about that more as well. So Mr. Smith, we learned, has had gradually worsening difficulties with his short-term memory over the past 2 years, as well as problems with executive functioning. So he's not remembering to take his meds, and his daughter has had to take over managing his finances because he was having difficulties. He's had increasing difficulties playing some of his favorite card games because he was just getting too confused and irritated with playing those games. He performed, his performance on the MoCA cognitive assessment was lower than expected. We also found that he's taking Tylenol PM to help with sleep difficulties. So where do we go from here? Well, from our history that we've taken with Mr. Smith, we have a picture of cognitive changes over the past 2 years, predominantly short-term memory, but also some difficulties with the kind of multitasking, planning out, carrying out tasks that are actually severe enough to impact his ability to be independent with managing his meds and managing his finances. So based on our definition of dementia, it appears that he does meet criteria for dementia. So where do we go from here? Well, this is just a preliminary, we call it a working diagnosis. We still need to get blood tests to evaluate for low thyroid and B12. We still want to get a brain scan to look for other potential contributing factors. But we also have already identified that he's taking Tylenol PM, which could be having a significant impact on his thinking and memory. And so we want to see if we can get him off of that and onto something else that is better for his brain to help improve his cognitive abilities. So going back to our cognitive aging trajectory here, with Mr. Smith, he does appear to be kind of on this purple line below the dotted line where he's starting to have difficulties with his daily functioning with his meds and finances. The hope is, though, if we get him off Tylenol PM, that might actually improve his cognitive level, and it's possible that might help improve his functioning. So we're always looking for factors that are reversible while also trying to identify other potential causes of dementia that may not be reversible. So back to our diagram of dementia, just to review, dementia is a syndrome. There are different causes of dementia, and we're finding more and more that most cases of dementia, of patients who have dementia, have more than one contributing cause or factor. And so we always want to do our full workup to identify what those factors are and improve what we can and support otherwise. So that is what I have for you with our talk, and I'm happy to answer questions and go through things and have more of a discussion. So thank you.
Dr. Weiss,